when she was not pregnant. Okay, so let's say when she was not pregnant, before she ever got pregnant, her diet was 2,000 calories a day. When she has a baby and wants to lactate, she should add 500 calories to her pre-pregnancy diet. So if she was taking 2,000 calories, she should be taking 2,500 calories. Okay, so that is for the baby.
Pre-pregnancy?
Breastfeed the baby. Okay. Again, you want to be supporting a choice of newborn feeding method. And again, I guess, see, that's the other thing that bothers me about Valley. I have to say that there's some people who just, for whatever reason, don't want to breastfeed. You know what I'm saying? So I really do believe there should be a person's judgment. Okay. So as much as we want to promote it, I also think that the woman has the right to choose what she feels comfortable with. Okay. So, you know, again, women are very sensitive and vulnerable after they have a baby. Their hormones are changing, they're down.
I see the football and basketball.
And if you're going to sort of like the
You
fact
play
that
basketball?
they want to bottle feed, they're going to feel like they're
Yeah, bring him
on
after
the
you. You'll school him.
So I just think that
He's good?
maybe, you know, they have to take
Huh?
into account.
He's good? He's mad good? Yeah? That's cool,
That's
man.
how I feel.
Not really.
Hmm?
Okay.
He's not good?
You
keep saying he's good.
I said he's not.
I'll train him. Okay, look at me. Look at me. I'm so athletic.
Yeah.
What's the average weight that a woman should gain during pregnancy?
If she's a normal sized woman before she gets pregnant, meaning her BMI is
She's Professor Goofy's mind.
20 to 24, something like that. 25 to 35 pounds. If she's heavy, less weight. If she's, you know, if she's BMI is 18 or something like that, probably more weight. 25 to 35 is the weight gain. Usually the first 3 months, the woman gains up to 5 pounds. And then after 3 months, every single week until she delivers, she gains about 1 pound a week.
Wow. So twins double and
Not necessarily double. They don't have to actually double. They might say, you know, 30 to 40 pounds. Yeah. So, usually if you stay within the weight gain guidelines, you will be able to lose
I'll
weight
help you. I'll help you.
within a couple of months after the baby.
Yo, I'm good at this. I pick up my sister's clothes. Guess what?
Okay, so teaching about breast care.
Sometimes.
Assessing the breast, measures to alleviate engorgement.
You should start dressing like a gothic. Like a goth.
To alleviate engorgement in the woman's breast, which means that she has milk that's, you know, not coming out because maybe the baby's not feeding enough, right?
Sit by
Basically,
me.
you want to tell her to try to express her milk, feed a little bit more. And if the woman is bottle feeding, she should just wear a supportive bra, not stimulate her breast. Promoting family adjustment and well-being, the parents in their new role. If there are siblings, you know, if the baby has a big brother or big sister come in, depending on the age of the big brother or big sister. If the big brother or sister is about 18 months old, it's not real to them. Okay, so in other words, they might, like my daughter did, my older daughter did to my younger daughter. When I brought my baby home, my 18-month-old took the blanket, put it over her head, and said, "Bye-bye." And I think he's the wrong one.
Watch. A little more to the right.
But anyway, I should. So anyway, so it's not real, you know what I'm saying? The pregnancy is so
Look, now you're gonna kill everyone. Dead. Are you? Who are you playing
If
with?
they're a little bit older, I've seen the cutest things in
Dexter's
the
left.
valley where, like maybe a 3 or 4-year-old will bring in her own baby
Nope.
doll. You know,
You're
and they
setting
have all the stuff, the same kind of stuff,
Yes.
the doll size. You know, the carrier and the,
Why'd you do that?
these things is really cute. So they'll
There you go.
3 or 4 will bring
There
in
you
their
go,
baby doll.
Kenster.
If you're a teenager, you're
Do it.
embarrassed as hell at your parents'
Power. All the way up.
If
Oh.
you are, you know, 14-year-old and your mother's having a baby, you're like, oh.
This
God,
guy
you know.
sucks.
But some people react differently, you know, it's just really the grandparent role.
You got it. You got it.
Again, usually they're very
Power
excited
down.
to have
Put it low. Put it
have
low.
a baby, a new baby, a new grandchild.
Oh my God.
And again, you get into
Don't
different
do it.
situations with different family members. You know that there's some of you, mother-in-laws who want to leave.
Yeah, because you know you did that on purpose.
Her ideas and everything you're doing is wrong. Or you have somebody who, you know, like my mother was, had nothing to do with my kids. You know, she wasn't interested, she never finished that.
Shit, I was recording the whole time.
So you have all sorts of grandparents who are out there.
What the hell?
Okay. Postpartum care for lactating women, I think we've discussed this already. It doesn't feel like we've discussed breastfeeding so many times already. Supportive bra, warm shower, shower to positions to put the baby on. Correct latch-on technique, usually want the baby's tongue under the nipple and that the whole areola gets into the baby's mouth. Inspect the nipple, expose the nipple to air, frequent nursing the baby, and increase the fluid intake. Okay. And this is just showing you
Told you.
Breastfeeding, baby body for breastfeeding. We want to make sure the mother is comfortable. When the baby shows signs that it's ready for feeding, a lot of times what happens is the baby will wake up and then we'll do the rooting. So if you touch the baby's cheek, the baby's mouth will open and go towards wherever
that would look better in
cheek
brown.
is touched. And that is the rooting reflex that the baby has. And that, you'll get that rooting reflex only if the baby's hungry. So if the baby's not hungry, she just was fed or he was just fed, he's not going to do the rooting reflex. Okay. You want to help her to latch on by bringing the infant to the breast with a wide open mouth. Okay? Not the opposite, not bringing the nipple to the baby, but the baby bring the baby to the breast. Okay? You want to listen for sucking sounds that the baby is actually taking in the breast milk. To remove the baby from the breast, you want to tell the mom, this will not irritate the nipple, is to put her finger, the mother's finger, in the baby's mouth so that you can let go of the suction. If you pull the baby off the nipple without taking the suction away, it's going to hurt and cause redness. Okay? So the way to get the baby off is putting your finger in the baby's mouth. Okay. Non-lactating women avoid stimulation of the nipples. Cold showers so that cold will constrict blood vessels and constrict the vessels to the breast. Okay, you know that in anything, cold will constrict and warmth will dilate. So she should be using more of the cold, the bra. Use ice packs or cabbage leaves for engorgement. Avoid stimulating breast and take an anesthesia. Now, the cabbage leaves, have I talked to you about that at all? It's sort of an interesting thing. Years ago at Valley, this nurse was a NICU nurse, actually. She was saying, oh, I give the patient cabbage leaves for engorgement or swelling of the breast. And I said, well, you know, would you come up and think, who in the first place would put cabbage on the breast? Like, well, that's what the such thing is. You know what I'm saying? It's like, yeah, it's like, oh, I think I'll put cabbage on the breast. You know, it's like, no, you know. So anyway, I read, there was an article in the New York Times a few years back, and it said some athlete had sprained his ankle, and the doctor recommended cabbage leaves for it too. So there's something in the cabbage leaves. What the nurse told me is that you put the cabbage in the refrigerator or freezer, okay, and then sort of break it up a little bit so the chemical, whatever chemical is in there, is coming out to reduce swelling. So supposedly this works. So I thought it was sort of interesting. Okay. Nursing management, postpartum period. Again, you're going to teach the mom about postpartum blues. Okay. You're finding your hospital, in Valley Hospital, and Wolf Hospital in New Jersey. We'll have a questionnaire to assess the mother for her risk for postpartum depression, or, you know, if she had it before or after. Every mother gets a check sheet. Okay. Discharge planning, you want to go over information about any kind of immunizations that she might need. If she's not rubella immune, okay? She will get that rubella vaccination on her last day there at the hospital, because it's a live virus, and they will give it to her as she's ready to be discharged home. They usually say to the mom not to have, get pregnant for the next 3 months. Some say 1 month, 2 months, 3 months, you know, within that range for the next couple of months not to get pregnant because of the fact that the rubella is a live virus and they, you know, get pregnant, something like that happens to the baby. They will do follow-up phone calls. There's one nurse named Judy who she comes in early for her evening shift every day and makes follow-up phone calls to see how everybody is doing, how is their stay at the hospital, you know, is there anybody you need to talk to. Lactation does the same thing too, okay? Outpatient follow-up, yes. Home visit, unless the patient has some kind of problem, they don't see, or if the patient goes home with, you know, within 24 hours, then it might be a home visit. Okay. And then we have, sorry. All right, discharge planning for the patient. This is recommended by, you know, the College of Obstetrics and Gynecology. State that the length of stay in the healthcare facility should be individualized for each baby. A shortened hospital stay may indicate you can do this shorter hospital stay, meaning they can go home after 24 hours if the mother has this criteria, okay? First of all, she must not have a fever, okay? She can be discharged home if her vital signs are all normal, okay? Her locus should be the appropriate amount and color and no odor to it the day she's going home. Okay. Her H&H, her hemoglobin hematocrit, should be within a normal range. They're a little bit more giving in the hospital. If a patient has like a 31% of hematocrit and maybe like a 10% of hemoglobin or 10% of hemoglobin, they usually say it's okay, they can go home, and I put them on iron pills and tell them to keep taking the prenatal vitamins. Okay. The urine fundus has to be firm. There should be urinary output that's adequate. If she is RH negative and the baby is RH positive, she has to get something called RhoGAM, okay? And they do that within 72 hours after she delivers. The surgical wounds are healing, no signs of infection. The mother's able to ambulate without difficulty, so she can get out the door and go home. Food and fluids are taken without difficulty. She's able to care for herself and the baby. The family or other support systems are available for her when she's goes home. And the mother's aware of possible complications, such as heavy bleeding, fever. She might get mastitis in the breast. And then again, we will do the rubella for the mother if she's not immune to rubella. If she is immune to rubella, we give her a shot of rubella. Okay. And other things that the patient should be aware of, there is no lifting for the first few weeks. They usually will say, don't lift anything heavier than the baby's weight. So if the baby is 8 pounds, you lift 8 pounds. The baby's 11 pounds, 7 ounces. You can lift that amount of weight. They just don't want you to overdo it. Pelvic rest means no intercourse. Okay. So pelvic rest for 4 to 6 weeks until she stops bleeding, okay, and her episiotomy is healed, or she has C-section until she stops having lopia. Sleep when the infant sleeps. Okay. Accept help from mothers when offered. Use a lubricant to help with vaginal dryness. Keep your postpartum follow-up appointment. For a C-section, it's 2 weeks after they deliver, usually, that they want the patient back. For vaginal delivery, it's usually about 6 weeks after she delivers. Okay. Report any signs of illness to the health practitioner. Now, this is go-to part of the syllabus of this says that we go to this chapter 22. Okay. And again, I'll just send this stuff to you. This is having to do with nursing management of the postpartum at risk. Okay, women at risk. Postpartum hemorrhage. Okay, it's life-threatening. So that's something that you really need to be aware of. Keep an eye on that lopia, the amount of lopia. The woman with the 11-pound baby, She was starting to bleed heavily afterwards.
That's why I
And
kept her on.
I kept her longer there because of the fact that the baby was large, so the uterus was stretched out. And when that happens, and also this is a fifth child, her uterus may not be able to start involuting okay. So she had uterine apnea and started to bleed very heavily. They also, somebody had told me that they think the baby had shoulder dystocia.
Yeah, they have to pull it off that way.
Pull the shoulder, like, because the biggest part of the baby is the shoulders.
It was very
Okay.
hard.
So, yeah, so they pull the baby out, the shoulders, so shoulder dystocia, the baby might have a fractured clavicle. That's what they had said to me, so, you know, because the biggest part of the baby is really the shoulders after the head comes out. So, that's something, seeing that now you understand it too, which makes good sense to you. Okay, let's see, the leading cause of maternal death worldwide is postpartum hemorrhage. More than half of deaths occur within 24 hours of birth. Blood loss for a what's considered a hemorrhage in a vaginal delivery is blood loss greater than 500 mLs. In a cesarean section, it's blood loss greater than 1,000 mLs. Okay. So again, they keep an eye on that. Any amount of bleeding that places the mother in hemodynamic jeopardy. Most common cause is the test question, uterine apnea. Okay. Early versus late hemorrhage. Early hemorrhage occurs within the first 24 hours of delivery, and usually that is from uterine apnea. Okay. Late hemorrhage occurs anywhere after 24 hours up to 6 weeks postpartum. Okay. Again, we know the early side or early type is apnea. The uterus must remain contracted after birth to control bleeding from the placental site. A full bladder can displace the uterus, which impedes uterine contractions. Usually with the late postpartum hemorrhage, a lot of times it's from infection or retained placenta. Okay. Other causes of postpartum hemorrhage include a laceration. Let's say that the woman tore, and she might be bleeding from that area. A episiotomy, sometime again, she might be bleeding from that area. Retained placental fragments is usually the most common cause of the late postpartum hemorrhage. Uterine inversion, we've already talked about that before, is that if they pull on the vocal cord to pull the placenta out, or if somebody's really pushing hard down on the mom's uterus to try to get that placenta out, the uterus can turn inside out. Okay? And that causes a severe hemorrhage. They can, once the placenta's out, they can push the uterus back into place. But while that's happening, she can lose a lot of blood. Okay? I've never seen that before. Coagulation disorder, so if she has bleeding problems, she might be, again, at risk for hemorrhaging. And if she has a hematoma, like that bruising with blood in it, and any of the areas, she is also at risk for hemorrhage. Again, therapeutic management, the first thing you would do with a woman who has uterine apnea is massage the uterus. Okay. That's what you would do. But then you would also have to see if her bladder is full. Because if her bladder is full, her uterus is not going to get firm. It's going to displace the uterus. So, initially you want to massage the uterus to stop it from bleeding, and then after that, assess to see if her bladder is full. Okay. They will remove any kind of retained placenta if the woman has a piece of the placenta still inside of her. And they'll give her antibiotics for infection and repair any kind of laceration that she might have. And so you want to do the fundal massage, pad count, make sure she's not saturating the pad every hour. There is medication. This is going to be on a test question. Okay. There's medication that the patient can be given if you can't stop her bleeding just by massaging her uterus. Okay. And they refer to it as a urotonic. Okay. The other thing they will do is administer fluids to the woman via IV. Again, you're hydrating her body up a little bit more, and you want to monitor for signs and symptoms of shock. Does anybody know what shock is doing that med surgery? So what would you think the vital signs would be in shock?
Decrease blood pressure, decrease output.
Yes, urinary output and increased pulse. Yeah. Good. Good. Abuse of the drugs. Again, this is chapter 22, and it's drug guide 22.1, drugs used to control postpartum hemorrhage. Okay. The first one, because you know how we talk about Pitocin, how when the woman wants to go into labor, it causes uterine contractions to occur and it causes her to go into labor. After she delivers, we want to keep the uterus contracted so she doesn't hemorrhage. So they can also give her Pitocin in her IV. It doesn't have to be piggybacked, all right? Sometimes you'll see that they will just put in 10 to 20 units of Pitocin into her regular IV after she delivers. And sometimes the orders will say the first 2 bags of IV should have this Pitocin in. That just, makes sure that the uterus contracts and it remains firm after she delivers. Okay. It stimulates uterine contractions to contract the uterus and control bleeding from the placental site. Assess the fundus for evidence of contractions and compare the amount of bleeding every 15 minutes. Monitor for vital signs. Monitor for uterine hyperstimulation, like hypertonia. Again, we want to keep an eye on that. Let's see. Explain what you're doing. Provide non-pharmacological comfort measures to assist with pain management. At that point, you could give a regular pain medicine because she's no longer pregnant, if she's in pain from the Pitocin. Set up the IV infusion to be picked. Now, it's usually into the primary IV one. They just put it into the primary IV one, the Pitocin. Okay. The other thing that they can use to stop a hemorrhage is called Methergin. It's the second one. Again, this will stimulate the uterus to prevent and treat postpartum hemorrhage due to acne or subinvolution. Okay. Again, you want to assess baseline bleeding, uterine tone, vital signs every 15 minutes. Okay. You want to tell the mom what's happening. Now, you want to monitor for possible side effects or adverse effects. Okay, so Methergin could cause the woman to become hypertensive. Okay, high blood pressure can happen. She could have seizures from the Methergin. She could have uterine cramping, nausea, vomiting, and palpitations of her heart. She might even have chest pains. So if you have a question of the 2, oxytocin and Methergin, okay, of those 2, if you had a woman who had high blood pressure in pregnancy, she delivered and still has a blood pressure now of like 150 over 90, would you give her oxytocin or Methergin? Oxytocin. Because Methergin, one of the first things it says for adverse effect is high blood pressure. It can cause high blood pressure. So if she already has high blood pressure, I'm not going to give it to her. Okay? So that's something you have to know for that exam. There's a prostaglandin. Prostaglandin causes contractions. When a woman has her menstrual period, she has menstrual cramps, some people, and the menstrual cramping comes from prostaglandin. Okay? So, they can give the woman prostaglandin when she's having postpartum hemorrhage because it will contract the uterus. Okay? So, the term that you usually hear for this particular prostaglandin is called Hemabate. Okay, that's the most common term or the name that they use is Hemabate. Okay, this will stimulate the uterus to treat postpartum hemorrhage due to uterine acne when not controlled by the other methods. So they try the Pitocin, they try the Hemabate, or they just try the Pitocin because the woman has high blood pressure. Then they would take it to the next level of Hemabate. Okay, we want to assess the vital signs, mom's contractions, her comfort level, her breathing status. Offer explanations to the patient. Monitor for possible adverse effects such as fever, chills, headache, nausea, vomiting, diarrhea, flushing, and bronchial spasms. So let's put it this way. If a woman has asthma, would you give her this? No, because this can cause bronchial spasms. So you have to know that so far so good is the oxytocin, Methadone if you don't have high blood pressure, and Hemabate if you don't want to use that if she has asthma or bronchial problems. Always remember the 4 causes of postpartum hemorrhage and the appropriate intervention for each. 1, uterine apnea, you massage, and you might be able to have to give her oxytocin drugs, like the one we just talked about. 2 is retained placental tissue. They may go in and try to scrape out or suction out the retained placenta, so it's evacuation of the uterus, and oxytocin. If she has lacerations or hematoma and causing her to hemorrhage, they might have to go in and do a surgical repair. And then if she has a thrombosis or bleeding disorders, she might have to have blood products given to her. Okay. That is.
Can you see that?
14 slides left.
Never mind, I got it. Never mind.
All right.
She just told us.
Thromboembolic conditions, okay, that's thrombosis, inflammation of the blood vessel lining, okay. The most common sites for this are superficial or superficial thrombosis, deep vein, DV, have you seen that? DVT, okay, deep vein thrombosis, or pulmonary embolism, which is really very deadly, okay. Why this happens is stasis, meaning that when she's pregnant, because of a big uterus, sometimes the blood in the veins aren't returning well to the rest of the body. Okay, injury to the innermost layer of blood vessel, or she has a past problem with hypercoagulation, or again she's still hypercoagulating when she's postpartum too. Okay. Teaching, assessment, risk factors, again, we talked about that, signs and symptoms, positive Homan sign, warmth, pain, redness or pinkness in the area. Prevention, again, you want to promote early ambulation, okay? They will put those little boots on the legs, not little boots, to keep her blood flowing in her legs, usually until she gets out of bed, okay? She can have NSAIDs, ibuprofen, bed rest. Okay, anti-embolotic stockings. Has anybody ever seen those kind of stockings? They have really hard to put on patient. I mean, I have them for my knees because I was told like, oh, you're on feet all the time, you stand all the time. Why don't you just get them? Put it in the I was like, how do you get these on? And then how do you get them off? It was really hard. But yeah, sometimes I do that. I don't see it as much anymore. I think I see it more in patients who have very bad varicosities when they're pregnant, that they will have a moment where, like, those type of stockings. Okay. Emergency measures for pulmonary embolism, which again can be deadly. Okay. Is the following statement true or false? Postpartum hemorrhage is most commonly due to uterine atrophy. Okay, that's right. Which drug would the nurse expect to administer to a postpartum patient with deep vein thrombosis? And then other things to look for, as we already spoke to, fever greater than 38 degrees Celsius, or fever 124 degrees Fahrenheit after, that's the question on the test, after the first 24 hours. Okay? So before 24 hours, it's acceptable to have 100.4. Right. It's pretty much staying right there. I'm surprised I did that after the test. Okay. Let's see. Organism, usually those of normal flora, vaginal flora, can occur and cause the woman to have an infection. Metritis is an infection of the endometrium, which is the lining of the uterus, and just the whole uterus as a whole. Okay. Wound infections can occur, like her having a C-section or episiotomy or a laceration. She could have urinary tract infections, mastitis. Again, that's that inflammation of the breast. Usually it's because of milk stasis in the breast. It's not moving. Usually they'll give them broad-spectrum antibiotics for the metritis. Metritis, again, is used to be called endometritis, okay, infection of the endometrium. Not in different parts of the uterus, not just in the lining. Wound care for wound infections, usually limited with normal saline, okay, and whatever from there, the person taking care of the wound side. Fluids and antibiotics for UTIs, urinary tract infections, breast emptying, and antibiotics for mastitis. So the woman needs to get her milk out from her breasts so the mastitis will not occur, okay, or if she has it, she gets antibiotics for it, but she can either pump the breast or feed the baby more often, okay. Infection prevention, again, aseptic technique, hand washing, perinatal hygiene. So this is the patient themselves, they should be doing this. Screening of visitors. We saw that big sign last week, stop. If you have at Valley Hospital, right up on the floor. Big sign, and this is when I was 17. Like, oh no. Stop. If you have like a cold, a fever, a sore throat, and a cough, basically get lost. Don't come onto our unit, And I'm like, I had all the above. So I said, I'm not going to talk to anybody. We didn't go in on the patients. But yes, so that's important in screening visitors. Administration of antibiotics, wound care, and chronic teaching. Okay. And then flus, depression versus psychosis. Okay, so baby blues usually occurs the first couple of days after the baby's born. It's from exhaustion. It's from hormonal changes. She's hungry. She's tired. All this, and the levels of estrogen and progesterone drop right after delivery, and that can contribute to the mood disorder. Okay. Again, what I just said, her exhaustion, lack of support, all that. 3 postpartum affective disorders that may be seen. Baby blues, depression, or psychosis. Okay. The affective disorders, baby blues or postpartum blues, is mild depression, tearfulness, feeling overwhelmed, along with emotional lability. What happens is she's up and down, she's tired. I don't see it that much because they're only there like 2 days. They might exhibit it more when they get home, okay? But sometimes you see the person almost like, it's almost like a manic depressive kind of thing where they're so thrilled that the baby's born and they can't fall asleep. They're so excited the baby's there, and then the next day you go in and they're crying. I don't know what's crying. And again, it's hormones are changing. You're tired and all that. Okay. So it's you're irritable. You have a little bit of insomnia. Okay. Blues. It peaks on day. That's why I don't see it day 4 or 5 after delivery. It usually resolves within 2 weeks. Or by day 10 postpartum. It's self-limiting. The blues do not usually affect the mother's ability to function or care for the baby, although 20% of these people can develop postpartum depression. Okay, so it's important to follow up on it. Postpartum depression. So you have blues. That can be just situational. Okay, hormonal. Depression is if the blues last beyond 6 weeks. It may be postpartum depression. As I said, greater than 20% of women develop postpartum depression. Major depressive episodes are associated with childbirth symptoms lasting beyond 6 weeks. Okay. What they will do is a postpartum depression screening tool before the patient goes home. If the patient seems to be at risk, they will follow up on her. They might give her antidepressant medication. They do have support groups at these hospitals. About Hackensack, they do have support groups that for the mother and the father. Fathers can go through depression too. Okay, so it's not just the mom. And then the woman is at risk for recurrent postpartum depression. So if she had her first pregnancy, or she has a history of depression, she's at risk for postpartum depression. If she has a big spurt. And that they usually have that on the patient's chart, history of her last pregnancy. So you're aware of that. Postpartum psychosis occurs in 1 to 2 out of every 100 women. It appears within 3 weeks of giving birth. These are the people who hear voices saying, "God told me to kill my child," or they're not in the right mind. Is basically what it is. They have sleep disturbances, they're fatigued, they're depressed. Early symptoms resemble depression, but escalate to delirium, hallucination, anger towards self and baby, bizarre behavior, thoughts of hurting or killing herself and or the baby. The treatment is hospitalization, psychotropic drugs, psychotherapy, and group therapy. Now, you think of that woman in Texas where she put all her kids, and she was told in her, let's say she had 5 kids, in her 4th pregnancy, she was told, her husband was told, she gets this psychosis, she shouldn't get pregnant again. She gets pregnant with the 5th one, she gives birth and kills all her kids, because she's psychotic. So, again, you don't, thank goodness it's not something you see a lot. I mean, I'm never hearing somebody, even in Allendale, New Jersey, the woman had given birth, her husband comes home from work and she's gone, she was her first baby, and she threw herself in front of the railroad tracks. I think this was a hopeless. Again, you know, I would think there'd be signs and symptoms before she got to that point, you know, but I'm not sure. Okay. Is the following statement true or false? Postpartum psychosis is the most severe form of postpartum psychosis. Okay, true. Okay. And then risk factors, signs of depression is in the book. Again, the only thing we could do as nurses is just give them the screening and refer them, you know, to a healthcare provider. Okay, and any questions? The people who are in Karen Gasco's group, you will be getting the tests for her to review with you on Thursday and Friday.